If you're an occupational therapist and you work with shoulders and you're struggling what to do with them, my name is Huang. I'm an occupational therapist and certified hand therapist, and I want to share with you a question that one of my students had sent in from inside the mentorship program. So if you're someone who works with shoulders and you kind of struggle to think about what to do with them, or maybe you're here because you want to learn more and wondering about what I do, I'm happy to share. So this is a question. Let me share with you the question. So here's the question. I just consolidated the question a little bit, but my student was sending in a question about a shoulder impingement who had a PRP injection to it and wanted to know, what is she allowed to do? Like, she's getting more motion without pain, but this person's very motivated. This is a dentist. They want to get their range of motion back. They want to be able to work. They want to be able to do their activities. But when are you allowed to do more strengthening? When are you allowed to do the arm bike and all that good stuff? So I'm going to share with you exactly how I think through this particular type of case so that you can think through your particular type of cases and think about what you're allowed to do and what you're not allowed to do. All right, so if you have a shoulder impingement, so I always think about the nature of the injury, right? The nature of the injury is an impingement, right? Impingement. This is a shoulder rotator cuff impingement. Now, this person had a PRP injection. So usually with a PRP injection, you're waiting a few days, 3 days or so, before you get started with any kind of exercises or range of motion. You just want it to rest for a few days, and then after those few days and up to like 2 weeks, you can start getting more range of motion, and then around 2 to 4 weeks, you can start to increase that motion and start increasing your ability to strengthen. So just because you say you can increase strengthening doesn't mean you're going to pick up 100-pound weight. It just depends on your patient's capacity at that time, right? So usually around 4 weeks, you're allowed to do even more. Now, think about, so that's a PRP injection. So you have to decide what your patient's procedure date. But think about what an impingement is, right? An impingement means the scapula to the humerus is not moving, in the way it's supposed to move. And so the humeral head keeps hitting into the acromion process of the scapula. So then in between that is your rotator cuff, and that's all that means, is that those two bones are hitting against that tendon and causing inflammation, irritation, which translates into pain and limited motion in certain planes over others. So my rule of thumb is, when I'm working with impingement, you've really got to nail down your range of motion. You have to really nail down your passive range of motion without pain, right? Without pain. Then you've got to get your active range of motion without pain. And then you can start your PREs without pain. Because the major contributor to rotator cuff is pain. And usually there's a very particular type of tightness that occurs. So I like to use my hand when I'm teaching my students about the position of the humeral head and the way that humeral head has to glide. Well, this is a glenoid fossa. So up at the top is the superior. So if you think about a glenoid fossa, right, as like a clock, the top is the superior, the inferior is the bottom. This is going to be your anterior, and this is your posterior part of your shoulder. I like to use my hand because this is your cheat sheet, right? So a lot of times the humeral head tends to glide and hit to superiorly and also anteriorly. That's why most of your patients have a lot of pain in the front, right? That's impingement. So if I have a humeral head that sits at the top and in the front, if I were to do an exercise like the arm bike, right? An arm bike. So my student's question is like, can I put them on the arm bike? I'm like, you could put someone on the arm bike, but is that the best exercise? Is that the best exercise or use of your time to put someone on an arm bike if you're trying to get rid of this impingement, because look at where the humeral head already sits. If you have an impingement, you most likely have the humeral head sitting very superior and very anterior, very forward, right? So a lot of them have pain here. So when you go and you do the arm bite, what is that doing? What is that doing? That is riding that bone further and further anterior. So can you do the exercise? Of course you can. In terms of the injury and the procedure, nothing is telling you that you can't do that exercise. Of course, that's range of motion, there's no strength behind it, so of course you can. But it's not the best exercise to do, because what happens is when you are having them push forward, all they're doing is you're using more pecs, using more biceps, using more anterior deltoid, and you're just getting them to do more of the things that is causing them to have the pain in the first place. So can you do it? Yes. Should you do it? No. I'm not a big fan of the arm bike. I used to use it as someone who, when I worked in the hospital, we used it all the time. It was always there. I saw other therapists using it. So they're like, again, the answer is of course you can, but should you? And it wasn't until years later that I was like, that exercise doesn't make any sense, right? And this is what I'm encouraging you to do. As a therapist, really think about the exercise or the activity that you have your patients engaged in, and ask yourself, is it helping you get the results you're looking for? Most therapists get really frustrated that they're not getting results for their patients, but I think a lot of times it's because you're not picking the best exercises. Listen, I've been there, and this is why I'm on here and explaining to you not just what to do, but why you're going to pick what you're picking so that you can make the best decisions for your patients. This is exactly what we do inside the mentorship program. We really focus on picking the best exercises and helping you think through your cases, because all cases, no matter where you work, no matter if it's the same body part, they're going to present a little bit differently, and everyone wants different things, right? So let's go back to, if we want to get better movement without pain, how can I ensure that I'm stretching it appropriately so that I can get better range of motion? Well, first of all, from a manual perspective, you want to do a posterior glide or an inferior glide. So the humeral head, it rolls superiorly and then it glides inferiorly. This is something I teach a lot, because you have to realize as someone raises their arm, first their humeral head rolls up and then it starts to glide inferiorly, so that when they come all the way up, it clears that acromion and it doesn't keep hitting into it. So what tends to happen is the inferior capsule gets tight, and that's why it sits so superiorly. The same with the posterior. The posterior capsule tends to get tight, so the humeral head tends to sit very anteriorly. So if you want to help your patients get out of pain, make sure that their capsule moves in the direction that it needs to be moved, so that you could get pain-free passive range of motion, and then you can start active. So now with active, you have concentric and eccentric. Oops, spelling it wrong. Eccentric. Oh my God, I used to have the hardest time remembering which one it was. One goes up and then one comes down. So concentric is up and eccentric is down. That's how I kind of remember it, because it changes in all planes. Like if you're doing external rotation, concentric is up and then eccentric is coming down, right? Same with the wrist. Concentric is up, and then when you're lowering it, eccentric is lowering it down. Muscles don't work all by themselves. They work as a group. They function together. So when you're working an active range of motion, you can, a lot of times people are sitting here, I want better forward flexion. But then they sit there and they do a bunch of forward flexion in a very poor pattern. Again, if your humeral head is not sitting in the right places, you can move all you want coming forward. It's just not going to get you pain free. You're not going to get your patients pain free. So I would encourage you to think about all directions. My favorite is actually working in the opposite direction. So instead of working forward flexion all the time, I tend to work extension, because when you work extension, and you have to work extension correctly, you've got to be mindful of the scapula. The humeral head, the humerus, the arm does not move well without the movement and the position of the scapula. So those two bones and those two movements and the rhythm between those two have to be taken into consideration. So are you allowed to do eccentric? Are you allowed to do concentric? Yes, you're allowed, technically speaking, from a PRP injection position. Of course you're allowed to. The whole point is you're allowed to move in a pain-free range. And so what I tend to do is I tend to work in the opposite direction so that I can get better motion in the motion that's most painful. So for example, if someone is very painful forward flexion, I don't work a lot of forward flexion. I actually will tend to work in extension with a lot of focus on scapular position, scapular plane, like how is that scapula moving? And when they go into shoulder extension, are they moving their scapula? Because some people are not moving their scapula. So if you're doing your exercises but you're not mindful of the form, and this is the biggest difference, you're not a personal trainer, you're not a well person going to the gym, you're a rehab specialist, meaning like people are coming to you and they're broken, so you have to pay a little bit more attention to the quality of movement and not just the quantity of movement, right? And so you want to look and make sure when they move their scapula, I'm in a big shirt today, so you can't see, but if I go into shoulder extension, but I round my shoulders and my chin comes forward, I'm probably not moving my scapula correctly. So when I bring my arm back, I want to pull my scapula and squeeze my scapula together, being mindful of my neck position. I'm always mindful of my neck position when I work with my patients, so they're not like overly compensating or stressing. But you can do either one. It's just which one is pain-free for your patients. And then as you get more into pain-free motions, then you can start to do progressive resistive exercises. And you don't always have to wait certain planes do better than others. And making sure that scapula moves is going to be really imperative for getting your patients, at the end of the day, they have an impingement, getting them pain-free and ensuring that they get really good results with their PRP injections. So this is a question from one of my students, and inside the program I tend to refer them to watch certain videos that are inside the program. I just wanted to share with you the question and share with you a little bit of my thinking. And if you like more videos like this, leave me a comment below and take a look at the link to join the mentorship program and see if it's right for you. All right, thanks.